Good evening or good afternoon if you're watching from BC. Welcome to tonight's webinar with a focus on stomas and IBD, what every healthcare provider needs to know. Our presenter is Dr. Kotze today, and myself, Marie-Louise, will be moderating. Today's webinar is hosted by CAN IBD. CAN IBD is a community of practice for nurses across Canada working in the field of inflammatory bowel disease. Our vision is to ensure people of all ages living with IBD in Canada receive high quality clinical nursing care within a multidisciplinary team. I apologize, the last part should have been admitted. CAN IBD is committed to improving the quality of care for people living with inflammatory bowel disease by providing mentorship and learning opportunities to IBD nurses in Canada. If you haven't already done so, please check out our website for fully funded fellowship opportunities and also research grant opportunities. We're also focused on creating opportunities for networking and sharing of best practice, developing and adopting nursing guidelines and standards for IBD nursing in Canada, and we aim to elevate the profile of IBD nursing in Canada. Tonight's speaker, we have the honor of having Dr. Kotze, a world-leading renowned expert in inflammatory bowel disease, colorectal surgery. Dr. Kotze is an adjunct senior professor in the colorectal surgery unit at Curju University, Hospital of Catholic University in Curitiba, Paraná, Brazil. He received his medical degree at the Federal University of Paraná in 1997 and completed his general surgery training at the Evangelical University Hospital in Curitiba. He also completed his senior fellowship in colorectal surgery at the Clinics Hospital from the Federal University of Paraná in 2002. Dr. Kotze achieved his master's degree in surgery at the Catholic University in 2008 and joined the Faculty of Medicine at the same hospital in 2011 as an assistant professor of surgery. He achieved his PhD studying the influence of biologic therapy on surgical outcomes in Crohn's disease at the University of Campinas in Sao Paulo, Brazil. Dr. Kotze was also an IBD Advanced Visiting Fellow at the University of Calgary from 2017 to 2018, which is how I have the pleasure of knowing him. Currently, he is a professor of the Postgraduate Health Sciences program at the Catholic University in Paraná. So I'd like to take this opportunity for thanking Dr. Kotze for giving us his time and also thank our webinar sponsor, Pfizer.
Thank you so much for having me here. It's an honor for me to participate in this webinar from this fantastic nurse program that you have. I would like to initially state that we don't have the privilege to work as close to nurses as you here in Brazil. It's one of the unmet needs in our health system here. And I'll try to emphasize to you that the importance of the role of nurses and also from surgeons to the care of patients with stomas in IBD. So it's my pleasure to be here with you, and what we would like to understand is how do we take care very well in a high level of standard for these patients with Crohn's disease and ulcerative colitis who during a phase of their treatments, they have to experience temporary or even permanent stomas. So any questions that you might have, you can place in the chat or the Q&A session, and then at the end, we will go through them. Approximately, we'll speak about 25 to 30 minutes, and then we'll have plenty of time to address some of the questions and, of course, some suggestions and comments that you might have. So stomas are a surgical step usually undertaken at the very end of long surgical procedures. For example, if you do an ileoanal pouch surgery after a total proctocolectomy, laparoscopically 5-6 hours, and then at the very end you delegate usually your loop ileostomy step procedure usually to your fellow or to your resident, and that's possibly one of the reasons that we have an overall complication rate of approximately 70% when you have the stomas in patients with Crohn's and ulcerative colitis. But to talk a little bit about a background, historical background, the story of stomas, they initiated a long way ago. So initially in the before Christ era, patients, mostly children with incarcerated hernias, they had to had some form of decompression, and in those days abdominal punctures to decompress the incarcerated hernias were described. 1710, Littré described the first colostomy for newborns with anorectal agenesis, and this was usually one of the most important developments of surgery in those times. But again, up to 1900, we didn't have that much of advance on these techniques. To be honest with you, in the early century, people like Miles and Kulicz, they started to develop the field a little bit more. The first description of the double loop colostomy to decompress and resect these patients' disease segments of the intestinal, small or large intestine were described by Kulicz, and then the first abdominal perineal resection was described in 1904, and Miles was in charge of making this a very famous operation since 1907. And of course, this was developed in parallel with the development of anesthesia techniques. And for you just to have an idea, the abdominal perineal resection that Miles described in 1907, still the standard of care for low rectal cancer cases of total proctocolectomies nowadays. It took us 50 years approximately to Dr. Brian Brook, who's in this picture on the right-hand side of the screen. He described the Brook ileostomy technique, and this was a major advance in the field because the output of an ileostomy is extremely alkaline. So his technique was even impressive when he decided to put this as a prolapsed segment of small bowel throughout the abdominal wall in order to make things easier for patients. And the last big advancement that we have was the description of the continent ileostomy by Koch in 1969. And after that, what we had is like development of stoma devices. So what are the indications of stomas in patients with IBD? Let's start with Crohn's disease. We can have end ileostomies, usually after total proctocolectomies or even segmental resections in emergency basis. We can have loop ileostomies to divert proximately an anastomosis or even perianal Crohn's disease, severe cases. I'm going to show you a picture in the next slide. We can do end colostomies, but this is becoming more rare currently. And of course, the double loop stoma, Kulicz procedure, where you have complicated ileocecal resections in the emergency phase, can be, again, an option. This is a case of a patient, a young patient with a destructed perineum due to severe anorectal Crohn's disease. You see that there's stenosis there, there's sphincter damage, there's incontinence, and clearly this patient needs a diversion because, of course, to have defecations the normal way cannot help healing in any form. So this is a clear indication, for example, for a loop ileostomy. This is a description of a double loop stoma, the Kulicz style, when you can place the two segments of the bowel that you have after the resection, and then the afferent limb, the efferent limb, they exteriorized on the same spot. This is useful in cases with complicated ileocecal resections for Crohn's disease. Well, what about ulcerative colitis? Here are most of the types and indications for stomas in use. We can have end ileostomies after total proctocolectomy or even an urgent total subtotal colectomy. That's usually a three-stage approach that we do in patients with severe colitis in the acute phase. Loop ileostomies are usually performed to divert pouches. That's the most common operation for us in UC. The continent ileostomy is more for a historical procedure by Dr. Koch in Sweden. And in some cases, we can have even mucus fistulas to manage the rectal stump. So let me show you a little bit about that. This is the only reference I'm going to give to the Koch continent ileostomy, because this is really something that's not performed everywhere. It's quite a complicated operation. You have to combine loops in order to perform a big pouch. Then you have a nipple that you exteriorize from the abdominal wall, and then you can intubate this. And this is usually indicated for patients with high output from ileostomies who can have renal insufficiency. But this is, as I said, restricted to some tertiary referral centers. And this is not a common operation to be performed in Canada. Well, a little bit about epidemiology. So surgical ostomy rates in Crohn's disease are overall decreasing. So we are having less ostomies currently as we used to have before the biologic era. This is population-based data from Calgary. As we can see, there was a reduction in almost 4% per year after the initiation of biologics. If we stratify that in elective versus emergent ostomies, we can clearly see that there's tendency towards a reduction in ostomies due to Crohn's disease in the emergency setting. And this is in tune with better disease control. However, elective ostomies, mostly the temporary or even the permanent ones, they are quite quite stable after the biological era. Despite the fact that we can reduce temporary ostomies as well, the rate of permanent ostomies, it's still stable. It's a non-significant increase in the annual percent change of 2.8%. But to outline this, that biologics are making the patient's lives better. However, these big operations of total proctocolectomy and end ileostomies in Crohn's disease, they are not reducing. So the permanent ostomies are quite stable in our practice. So classification of stomas, we have, depending on location, the configuration, and the possibility of reversal. We can go through that in the next slides. So these are some examples that you can find. Letter A here, you have an end ileostomy, a Brook type ileostomy. On B here, we have a loop ileostomy. C here, we have a Mikulicz double loop stoma. So we have here the transverse colon and the terminal ileum exteriorized in the same place in the abdominal wall with a partial suture on the posterior plane. This is a patient with an end ileostomy and a mucous fistula, as I said, to manage the rectal stump after total colectomy for urgent acute ulcerative colitis. This is an end colostomy, sigmoid colostomy after sigmoid resection for perforation in patients with IBD. This is a scenario. And this is a rare case of a sigmoid loop colostomy that we use sometimes just to divert the transit in patients with incontinence of perianal disease or distal anastomosis. So this is in tune with the type and location of the stoma. And of course, this has to deal with the anatomical part of the bowel that you have to sterilize. So again, some schemes here to make it clear to understand. I would like to outline here to you the end loop stomas. This is a very different type of stoma that we have, because usually in obese patients, you know that obesity is now an important problem in North America. And sometimes the part of the bowel that we need to sterilize in an end stoma doesn't come comfortably without tension through the abdominal wall of the patient. So what we need to do is to do a loop stoma with an end blind. And this is usually indicated for obese patients where you cannot exteriorize a terminal or end ileostomy in a proper way. So just for technical purposes. Well, what about the role of the nurses? So demarcation is a very important part of the stoma care. I'm a surgeon, and you know we have to do it ourselves here, but I'm quite amazed how we surgeons do badly on that. Mostly in emergency situations, usually your focus is in other, part of the care of the patient, but demarcation is a very important part, because if you do demarcation in a correct way, you can reduce a lot the morbidity of stomas. There are some principles, of course. You have to be far from natural or surgical scars. Usually we can have the stoma placed in a place where you have 5 centimeter margins of plain skin without any folds in the skin, without some distance apart from bone structures. The stoma needs to be transrectal throughout the rectus abdominis rectus muscles. And we have the demarcation when the patient is in supine position, but also when it needs to sit the patient, because when we do that, sometimes we can have some skin folds that can make your life very complicated in the care of the patient after. We have to be careful with the clothes the patient are used to wear, the belt positioning. And when you do a very well undertaken stomach care, you can probably have the patient one day before the surgery. You can explain to the patient about the devices and the bags. Then you can place a bag, for example, for 24 hours, and then see how the patient has it for the next day of the operation. Here are some techniques for demarcation. The most common one is this one. So you can draw an imaginary line between the umbilicus and the anterior spine of the hip, and then another line from the pubis to the nipple. And usually in the intersection of those lines is the ideal point for the stoma. Then we sit the patient and we see if the patient does not have any skin fold that makes it difficult. Other techniques is like the middle angle of each internal angle of this triangle between the umbilicus, the pubis, and the anterior sacral spine, hip spine. As we can see here, these places are often the same. So independent of the technique, you have to do it. That's the most important part of it. Here's an example for us. We have here the marking with the midline and the best probably the best spots for stoma side are these in the right and also the left-hand side. Sometimes, usually we do both sides because we never know what's going to happen. So sometimes the patient has an anatomical impairment of the mesentery, and then the stoma does not sterilize very well. The one side, we always can have the other sides in a mirror basis, usually in the same spot. A little bit of surgical technique. Usually, as we said, this good stoma needs to be transrectal. One of the most important discussions that we have with our nurses who take care of patients afterwards is the distance that the stoma needs to have apart from the midline incisions. Once we do it laparoscopically, it's not a problem, but when we do open surgery, there's a clear need for you to have at least 3 to 4 centimeters away from the midline incision because it's easier for the stoma bags to be placed. What we do is like we do a circular incision in the skin, we do it a cross-type incision in the muscle, we simply split the fibers of the rectus abdominal muscle, and then we open the peritoneum and throughout the rectal abdominis muscles, we exteriorize the stoma. Here we see it in another way, and again, the rectus abdominis muscles is a muscle that varies in terms of width from patient to patient, and usually what I see sometimes are general surgeons doing stomas like this far away from the rectus abdominal muscles, and with that you can have an increase in complications such as, for example, parastomal hernias. The ideal stoma is fixed on the aponeurotic plane and without tension. It does not have any tension. This is a demonstration of a maturation that we do. We close the skin, we suture the skin and the stoma in a separated way, so it's interrupted stitches that we do with absorbable sutures. And these stitches usually they fall from themselves. You don't need to take them down. Laparoscopically, this is what we do. Of course, it's better to do it laparoscopically when you're simply doing, for example, a diverting stoma, because the patient does not have a midline incision scar, and this makes their lives easier. A little bit about the ileostomy. So the Brook ileostomy, the classic Brook technique is this one. So we have the feet or the inferior part of the patient here, the head of the patient, the superior part is here. Usually we have 2 sutures with 5 centimeters in the proximal part, and on the distal part, we do it with 4 centimeters. By doing that, usually what we do is we have the stoma in a 30-degree angle, as we see it here. And this angle is important when the patient is standing up or walking. The output goes straight to the stoma bag. And with this little bit of inclination, it makes a full difference for the patient to the output to not make contact with the skin. So this is usually what we do. The output comes downwards and does not contact with the skin, and it reduces the rates for skin irritation. Here's an example from a loop, from an end ileostomy, the real classic Brook ileostomy, as we see here. This is approximately 5 centimeters from the midline incision. This is a stoma which is not ideal. It's a little bit lateral, in my opinion, but even though sometimes it's what we can do to have it well placed. This is a loop ileostomy. As you can see here, the distance is ideal, probably 3 to 4 centimeters between the stoma and the midline incision. Here's what we do with the exteriorization of the prolapsed part of the afferent limb. The efferent limb, the output sometimes enters this a little bit, but this is easier to reconstruct. So when you want to restore the fecal stream, it's easier for you to just release this part and just do a simple suture. That's the main advantage of the loop ileostomy. Here we see an end colostomy from the sigmoid. So it does not need to be so prolapsed as the ileostomy. Usually when you have a 1 or 2 centimeters prolapse with a colostomy is okay, because the output here is more solid. When you have an ileostomy, you have to have 4 or 5 centimeters because of the output, because it's usually liquid and alkaline. Here's an example of a loop colostomy. Usually we do some rods in patients that are at risk of retraction of the bowel wall segment. This is not done anymore. I would like to state that to you, because the rods are not a standard of care. This is what we have done over the last 15 years or so, but right nowadays when there's no tension, we do not use rods anymore, because I think this can increase complications and make the life of the stoma nurses more difficult. The loop transverse colostomy is rarely used in IBD because of the complications. We have several complications from transverse loop colostomies, mostly prolapse. And this is a big problem for us because to take care of this patient with devices or stoma bags is quite difficult. It's challenging. So this is a patient with a prolapse of a loop transverse colostomy, and we have to correct this surgically. What we do is simply take down the transverse, the prolapse part, and do, for example, a proximal colostomy and a mucus fistula, or you can even resect that and close the efferent lumbar and just do an end colostomy if possible. Sometimes you have to do that because it's a very complicated complicated position for patients. So let me show you now a little bit of our experience. So we published recently our experience with 121 stoma procedures exclusively in IBD patients, 60 patients with Crohn's disease, 28 patients with ulcerative colitis. This is what we have found here. As you can see, the age of the procedure was similar. Baseline characteristics of the patients in terms of medication they were using was quite similar as well. But we had some differences, mostly on the indication. So patients with UC, usually we do loop ileostomies to divert distal anastomosis more than Crohn's disease. And Crohn's disease, we use the stomas more in the emergency setting as compared to ulcerative colitis. As we also said, the type of stoma varies from the diseases. Usually we do more loop ileostomies in UC than CD, and in CD we use more end ileostomies or terminal ileostomies in these patients. And again, most of our permanent stomas are in Crohn's disease and less are in ulcerative colitis. When we check complications between the two diseases, we'll see that there's absolutely no difference between overall or early complications. However, late complications seem to be more common in Crohn's disease, 20% as compared to only 5% in ulcerative colitis, and late complications mean more than a month after the procedure. And what are these complications? The most common ones are skin irritation, as you can see here, very commonly in both Crohn's and UC, ischemia of the stoma, also common, and dehydration or even renal insufficiency that can happen mostly because of fluid and electrolyte imbalances in ileostomies in both diseases. Late complications, parastomal hernias, quite common in UC, or mostly in our experience, we did not notice one single patient with Crohn's disease with a parastomal hernia, but this is, of course, has to deal with the follow-up. The longer the follow-up of permanent stomas, the higher the risk for a parastomal hernia. We can have also some pyodermas around these stomas, fistulas, strictures, and disease recurrence. So let me show you a couple of examples here. On the top left, we see a patient with skin irritation and mucocutaneous separation. So this is a big problem. Allergy to stoma bags, skin irritations because of course, we cannot adapt devices so well in this patient, and this is a patient who gives you a lot of trouble. Usually these are malnourished patients with chronic problems. Here we see necrosis in the stoma prolapse, the necrotic stoma prolapse here. Disease recurrence, some ulcers here around colostomy area, and we're going to come back to that. Stenosis, here you can see stenosis from an ileostomy, pyoderma gangrenosum in an ileostomy patient with Crohn's disease. And here you see fistulas, peristomal fistulas in a patient with Crohn's disease as well. So these are some examples of complications that can happen. Here in detail, pyoderma and some skin irritation. Here you see some ulcers from disease recurrence in a patient with Crohn's disease, ischemia and necrosis from a colostomy in a patient with segmental colectomy. Here you see a very big parastomal hernia. And see, this is the type of patients we sometimes even see in 2023 in the public setting in a country like Brazil, absolutely without good care in terms of stoma bags and orientation. These are patients that suffer a lot. Here's another one. Here's a patient with a big parastomal hernia that needs correction, as we can see. Ischemia, this is a very rare event, so to say. This is a patient with ischemia in the ileostomy. And this is technical. This is purely a technical problem because it's all about, cutting the bowel in the right place. If you don't have a good blood supply in this part, you will have this kind of problems. And this needs immediate surgical correction. There's no way this can improve waiting for it. Stenosis, as you can see here, this is a problem from a colostomy. This is a stenosis colostomy. And these patients, they suffer a lot because they have to intubate this and to do some some form of emptying this by doing even irrigation. Well, as I said, the problem with Crohn's disease is the recurrence that we see in colostomies. For an unknown reason, mostly due to probably microbiome problems. Crohn's disease does not get along very well with colostomies. They prefer, the results are better with ileostomies because of recurrences. So usually when we do colostomies, we see recurrence in the skin, and we see recurrence in the colostomy site in patients with Crohn's disease. And this usually needs correction. So patients have to have an extension of their protectomy or even from the colonic part and have some ileostomies in order to control that, because even with optimized medical therapy, this can be a problem in Crohn's disease. So we prefer to do ileostomies in Crohn's disease as compared to colostomies. And of course, the same in UC. Let me just finish with some unusual situations that we have. So this is a patient with a big laparotomy, as you can see here. And this was evisceration throughout the stoma site. So of course, the patient needed correction. We needed to resect this and correct the evisceration and then place a loop ileostomy in the other side. And we already closed this in the same surgical step. Another patient with several operations before, and this is a patient who needed at this time a pouch with an ileostomy. So where would you place an ileostomy here? So if you do demarcation, probably this is the ideal spot for him. And this patient has already had a previous ileostomy in the past. So it's very problematic sometimes to place the stoma in an ideal place. And here, usually we had to do the ileostomy upwards here, far away from scars and from structural damage, of course. This is again an unusual situation, patient with an end ileostomy on the left side. This has to purely do with technical things. Here he had a very problematic sequela of peritonitis on the right lower quadrant. So the bowel couldn't come through this inflamed part of the abdominal wall, so we have to do it on the left-hand side. And some patients with big problems such as this. This is a patient with peritonitis. She underwent obese patient, abdominal hypertension, so we had to do peritoneostomy. And usually it's a very big problem to exteriorize stomas in patients like this when they have hypertension in the abdominal cavity. And usually we do that, and as you can see here, there's no adequate perfusion in these patients. Again, another example of that, and these patients usually have a lot of problems. Patients with stomas in one side, mucus fistula in another side, and usually when they have big abdominal hernias, and in this patient specifically, he needed a mesh to close the abdominal wall. And when you deal with intestines, even if it's a small bowel or colonic part, we have, it's a potential contamination for these kind of meshes. And this patient underwent chronic infection, and he needed to have a withdrawal of the mesh in order to get better. Very young patient. And again, sometimes the surgeon is the problem. So usually when the surgeon is not enough experienced, he does things like this. So a skin fold, which is totally unnecessary here. Usually to place a stoma bag here is a significant problem. So why don't you just, place them in the same part of the skin? It's something that technically you can improve a lot when you just do a double loop stoma in the same hole as we have done here in this scheme on the right as a Mikulic's part of it. So sometimes we surgeons are the ones to blame when you nurses that you have problems in taking care of these patients. So I think we're coming to the last slide, and my final messages before we can have some questions and discussion with you guys in the chat or even live and with Marie-Louise. Demarcation and an adequate surgical technique leads to success. This reduces complication and morbidity. So for young surgeons, what we teach here is anticipation. You have to think ahead of time. Once you have the abdominal wall opened in the middle of the procedure, you say, oh, this patient will need an ileostomy, for example, and you didn't do demarcation. This is a big problem for you because you will place the stoma on a place that's probably not ideal. So anticipation for demarcation is a very important part from our perspective. We have to give value for a stoma because this is the surgeon's signature. It doesn't matter if you have done a perfect pouch, for example, and the patient is having trouble with a loop ileostomy and not enjoying the good results of your big part of the operation. So this is a very important part. Usually when we come to the end of a procedure, when we have to fix and do the maturation of a stoma, we keep our eyes very, very tight on our junior colleagues in the surgical team. So meticulous surgical technique is important to prevent complications. And again, the role of you as stoma nurses in the MDT for IBD management is essential. So you can do that by not only doing demarcation, but also counseling patients of what are the expectations. Usually we have some leaflets that you can talk to patients, and we don't have easy access to that in the public setting, but in the private setting, what we do is a primary consult before surgery with the stoma nurse. And this, of course, reduces patients' anxiety and prepares the patients in a better way to live with a stoma, even if it's a temporary one. So in terms of our own data in IBD, ileostomies are the most common type of stomas. Late complications were more common in Crohn's disease. And of course, usually stomas in UC, they are temporary. And that's why it's the reason, because permanent stomas are usually more common in Crohn's disease. And even with the advancement and development of new drugs and strategies in medical management, patients are still needing ostomies, and as you have seen in the population-based data from Calgary, we have a reduction probably in emergency procedures, but not in overall rates. So I think we still need to discuss this not only with surgeons, but also with gastroenterologists in MDT in order to emphasize the essential role of stoma nurses in taking care of these patients. So this was my last slide. Thank you for your attention. And now we can have a discussion with Marie-Louise. And I see there's already some comments, Marie-Louise, here in the chat and the Q&A session. So I'm not sure if you want to read that, and we're going to take it, and then I can answer that.
So one of nurse practitioners out in Ontario, Irina, was asking if you have any specific recommendations or clinical pearls for demarcation in severely obese patients.
Yeah, this is a big problem, and there's not much that we can do, Irina. So obese patients, usually we can place the stomas probably in an upper part of the abdomen, because it's where you can place stoma bags in a better positioning. The folds of the skin in obese patients, they make your life very hard sometimes. And we see that obesity is a big problem currently, not only in Brazil, but mostly in North America. In the States, it's a really big problem. The BMIs that patients are being operated there is huge. So as I said, we have to explain to patients that in their operation, when you have planned a stoma, they can have problems. So the first thing is to try to make them understand that this can be associated to complications. So demarcation is essential for them. And usually in obese patients, what we do is we try to position these better ideal places for stomas in the higher part of the abdomen, because this is better for them. Usually they have a lot of problems below the umbilicus in the right and left lower quadrants when they have stomas.
Thank you. My question, which I think we talked about before, is with some of the transition patients, the people moving over from pediatric care to adult care, when they've undergone anal pouch anastomosis for refractory UC, during the initial surgery step, I am seeing, and the pediatric nurses have commented as well, that they're leaving more of the colon in during the initial surgery. And are you able to comment as to why that might be?
Yeah, so this is a big question and a good one, because this is purely technical. When they leave more a longer rectal stump or a sigmoid stump in the first procedure, which is the subtotal colectomy, it's purely technical, because when you're going to enter the pelvis in the future to dissect it and to do the pouch operation properly, it's better to have virgin planes that were not dissected before. Because if you dissect lower in this level, below the level of the promontory, you can have a fibrotic pelvis, and this can have more bleeding in the pouch procedure, the second part of the procedure, and it's more difficult. So usually what we say is don't touch the pelvis and do a long stump. If it's friable, you can exteriorize it as a mucus fistula. If it's a good tissue, you can just staple it and place a drain to decompress it if you have a stump fistula. And this is our practice at this point.
Thank you.
So it's purely technical. Purely technical, just to make your life easier when you do the pouch operation.
And does that may have any difference in fertility for those patients in the long run?
Yeah, we can. So pouch surgery can be associated with a reduction of fertility in female patients. Not only pouch surgery, but abdominal surgeries for Crohn's disease as well. We have a systematic review published on that. Laparoscopically, it reduces the chances for you to have infertility. So if you do laparoscopic pouch, laparoscopic surgery, and this is of course in association with a reduction in adhesions to the fallopian tubes. And patients can get pregnant the natural way. And a study from France demonstrated that comparing patients with UC in pouches performed laparoscopically in one group and the other group, patients with appendectomies, there was no difference in the pregnancy rates in the long run. So laparoscopic surgery is better to reduce infertility, but in open surgery, it can be a problem. So patients with pouch can get pregnant. If they cannot do it in natural way, they can always have an IVF, and this is something that they can do. Another point is that there's a reduction of fertility as well in patients with severe perianal Crohn's. There's nothing to do with adhesions to fallopian tubes. This is usually done for sexual quality of life and, of course, sexual function that these patients might have.
And we have another question in this chat box. Is there a limit to the number of stoma revisions that can be done, either from complications, from hernias, misplacement of the stoma, or if they develop pyoderma gangrene, pyoderma around the stoma site?
Yeah. So that's an excellent question, Jennifer. So there's no limit for you to try to improve your stoma. But usually when we say that there's only two good spots for stomas, one in the left side and one in the right side, we are not kidding. So we only have these two good sites to do that. So if you keep the stomas on the same spot, you can review them as much as needed. So usually what we can do is to resect a little bit more of ileum and then exteriorize a healthy segment. We can do it in the same spot. But the question regarding pyoderma gangrenosum is very important. So pyoderma gangrenosum, peristomal pyoderma gangrenosum, is not a good indication for you to, resect the skin and redo the stoma, because it will come back. So pyoderma gangrenosum needs optimization of medical treatment and topical treatment as well. Usually what we do is tacrolimus and optimization of medical therapy, and resecting it and replacing the stoma on the other side is the exception. So I've done that rarely, like 2 or 3 times in my career only. Usually pyodermas get worse when you have inadequate stoma devices placed. So I think this is also an important message for you. So if you are nurses and taking care of patients with pyoderma gangrenosum, so remember that when you do, for example, debulking of the borders of the pyoderma, or even you do a resection of it, it will come back. So there's a big chance of recurrence in these patients. Okay, so there are patients that we have done like 3, 4, 5 revisions and whenever needed. If they have stenosis, if they have recurrence of the disease or peristomal fistulas, for example, it can be a type of management.
And for patients that you've done temporary diverting ileostomies for complicated Crohn's disease, I've seen a number of patients do quite well symptomatically with their ostomy, but hate it on medical therapy, and they ask to go back and be reconnected. And then shortly thereafter are flaring again. From your surgical perspective, do you see people do well with temporary diverting ileostomies after they're reconnected, or do you find you're bringing them back to the OR to go to a permanent ileostomy?
Yeah, so excellent question again. So for Crohn's disease, this we're talking about severe perianal Crohn's or even distal Crohn's disease. So if you just place, for example, a loop ileostomy, patients can get better. You can optimize even your surgical care of the perineal fistula. We can optimize medical therapy, and if the patients heal the perineum, you can try to reconnect them. Some patients, they are not so well and they still want the reconnection because, of course, they want their stomas back in again. However, these patients, the minority of them, in the long term, they can be well after reconnection. Usually you're right, when you reconnect them, they can have flares, they can begin to have active disease again. And in a systematic review, just for you to have an idea, only 16% of the patients that have a temporary, let's say between brackets, a temporary loop ileostomy, they can have a good reconnection without proctectomy in the long run, in the long term. So it's the minority of patients. Usually in the very severe cases, the so-called temporary loop ileostomy is a bridge to a permanent stoma. If you have done a loop ileostomy and the patient is totally healed and you reconnect them and they never flare again, probably didn't need it at the first step. This is what I usually say.
So I have to tell Dr. Faraz he's right. That's what I
Yeah,
hear.
Dr. Faraz is right. He's usually right. Don't argue with him.
Our next question, what would be the criteria for creating a knock pouch?
Yeah,
Sorry.
cock pouch. So, yeah, so Claire, excellent question. So I have to tell you that I have a lack of experience on the K pouch. It's a very complicated procedure to do, but the criteria is very clear. So patients, mostly those with UC, who have a total proctocolectomy and an end ileostomy, and they have problems with high output of the ileostomies. So they have, electrolyte imbalances, renal insufficiency. These are patients that you can do a cock pouch with all those, complicated designs from the small bowel, and this will keep the output in that pouch, increases absorption and will decrease the chances of dehydration, fluid imbalances, etc. So is there a contraindication in Crohn's disease? Not absolute, but it's a problem because, as you know, Crohn's disease can commit every segment of the digestive tract. So if you do a K pouch and the patient has a recurrence of Crohn's disease in the K pouch, it's a big disaster. So the ideal patient would be a UC patient. And then you may argue, well, but most of my UC patients, they have pouches. They do not have total proctocolectomies. Elderly patients, those with low rectal cancers, those patients with bad sphincters, these are patients for total proctocolectomies and end ileostomies. And these patients, some of them, they can have problems with an end ileostomy and they are candidates for a K pouch, cock pouch. So this is the criteria mostly.
Thank you. In regards to the timing of biologic reinitiation after surgery, from a surgical perspective, is there an ideal time to start? Or is it dosed through like they were, keeping on their dosing schedule like they were before going to surgery?
So the ideal thing, Marie-Louise, is to keep the regimen they're doing. And we usually what we do is to do surgery in the middle of the cycle for the patient in order for the patient not to lose doses. And again, this is easy with the infliximab or ustekinumab when you have doses every 8 weeks or every 4 weeks. This is easier because you can operate patients 2 weeks after the dose, and then you can have the next dose 2 weeks after surgery again. But in patients with, for example, weekly adalimumab, this is quite impossible. And usually what the message is, we are not afraid of biologics. Most of the patients that we are operating that need stomas, they have residual disease elsewhere, so perianal or even proximal or distal to the stoma site. So these are patients that we try not to interrupt their dose regimens of anti-TNF or other biologicals. So in order to make you a summary, we can restart the biologic as soon as we rule out surgical complications and infection, and the patients are good to resume the therapy. Usually 2 to 4 weeks. This is what we do.
Thank you. For women of childbearing age, if they are undergoing surgery for refractory ulcerative colitis, do you have a recommended time they're trying for pregnancy? Would you say try for pregnancy while they have their temporary ileostomy before they're reconnected, or would your recommendation be after they've been reconnected?
It depends a lot. So, of course, this needs to be individualized regarding the age of the patient. So if it's an older patient at childbearing age, so to say late 30s, early 40s. So what we can do is like we can maybe control the disease activity in the rectal stump and then talk to the patients and say, look, this is a good timing for you with your end ileostomy to be pregnant now, and then we can delay your pouch procedure after you have your child. So this is a good point. But very young patients, they do not want to live with the stoma for longer, etc. So if the first operation was done by laparoscopy, we can go ahead with the pouch if patients agrees with that. And then it's better to have the child after the steps of the procedure, so after the loop ileostomy closure at the end. if you do it laparoscopically, because the infertility rates are not high, as I said. However, if it's an open procedure with some abdominal disasters, infertility can be a problem. So usually we can counsel them to have in the MDT people, for example, like Cynthia from Calgary. She's an expert on pregnancy, IBD, and lactation, etc. And we can counsel the patients with OBGYN in order to try to have the ideal timing for that patient. So for us, surgically speaking, there is no problem for a patient to get pregnant with a stoma or with a pouch. For us, it's not a big problem. But in patients like that, depending on the age, we can go ahead with the procedures and then try to get pregnant. And if we are not successful, they still have time for an IVF. But in older patients, when you do the first procedure, what we do is go ahead with it, have your child, and we delay your pouch construction for a future.
With the advent,
excellent questions. These are excellent questions. You guys are so experienced on this.
With the advent of our new biologics, so upadacitinib and Skyrizi, do you think we will see less patients with Crohn's or ulcerative colitis having to go to either temporary or permanent ileostomies, or do you think we'll just be pushing out surgery dates by a couple of years?
Yeah, I'm afraid of that, delaying surgery, not avoiding it. So I don't think that the new drugs are the ones that will, reduce surgical rates. I think it's early treatment with a drug that works for the patient. It can be an anti-TNF, it can be Vido, it can be ustekinumab, or the new ones like, for example, Skyrizi, or even now you're going to have UPA coming. So this early treatment with JAK inhibitors for UC or those anti-interleukins for UC or CD, the new treatments, they can work well as the other biologics because the therapeutic effect is quite in the same level. We don't see like a huge increase in response rates with these drugs. They're good. They're as good as the others. Some they have some advantages, but these drugs, they probably can work well in the failure of anti-TNFs. And this is, of course, a good thing for us. So I think early treatment, treat precisely, do not delay, and be comfortable. Some residual disease activity is something that we need to take into account. Cycling from drug to drug can only delay an operation. So I think that if we operate patients in the proper timing, we can operate them in a better nutritional state without that much of disease activity, and we can do surgery without stomas in these patients. So I don't think we are going to reduce that only because of the drugs, but to treat these patients earlier.
Thank you. Jennifer has a question. If a patient reconsiders having a temporary stoma reverse, does a more permanent stoma surgery need to be done, or can it stay as is?
Okay, so if I understood correctly, Jennifer, the question is to having a permanent stoma reversed, or if you can just leave it as it is or do a permanent stoma instead of that. So usually you see in pouch patients, if the patient is asymptomatic and is not having trouble with bacterial overgrowth in the pouch, they can stay with the, let's say, the loop stoma, which is a temporary one for long term if needed. So to convert that in a permanent stoma to excise, for example, the pouch and do an end ileostomy instead of a loop one can have advantages if the patients are having trouble with the loop stomas. The loop stomas are quite challenging to manage sometimes. The end stomas are easier to manage from the stoma nurse perspective. So some patients, if they have a lot of stoma complications, it can be beneficial to them to try to do a more permanent type of stoma. So an end stoma as that. And of course, there's always time to go back. And this is something I teach the patients a lot. So look, we can close your stoma. And if things don't go well for you, your quality of life is not improving, we can always go back and place the stoma again. And this is something that they're very comfortable to hear. Some of them, they even ask, look, doc, I was better with my stoma. So let's go back 2 stages and give me back a stoma because I was feeling better and my life was better. And this is a problem that we see sometimes in IBD.
Thank you. Are there any other questions out there?
This was an excellent question and session. It was excellent. Very nice questions, Marie-Louise. You guys are very experienced on that.
Well, it looks like that might be it if we don't have any last minute questions. So thank you, Dr. Kotze, for your time and expertise. it's always a pleasure listening to you present. Always get numerous pearls of wisdom. So thank you again. It looks like everyone's saying thank you and good night. So thank you everyone for participating and joining in on our webinar tonight. I look forward to seeing you at the next one. And thank you again, Dr. Kotze, and have a good night because I know it's later down there in Brazil.
Thank you so much, guys. Thank you for the honor to participate. Bye-bye. Bye-bye.